Okay, so I decided to do my case study on venous thrombosis. I currently am working at my clinical site, so one of the ultrasound techs that worked there came and talked to me about it, and so it was cool because I was able to go back and see which images they got from that. So a little introduction here. It was a 68-year-old male patient that presented to the emergency room with left upper extremity pain as well as edema to the left upper arm. So the ER physician decided he wanted to order an ultrasound of the left upper extremity with venous duplex. So a couple of things that this could have been, as far as differential diagnosis goes, could have been mediastinitis, superior vena cava syndrome, malignancy, or venous thrombosis. Okay, so here are the images that the ultrasound tech took from the study. They started with the left internal jugular vein. You can see that they used dual screen imaging to demonstrate the jugular vein with both with compression and no compression. So on the left side of the screen, you can see there was no compression, and then on the right, they did compress the vein, and they used calipers to measure the vein with compression. You can see that the vein did not collapse with compression. Okay, so next they went long on the vein and put some color on it. You can see the internal jugular vein has no color at all in this image, however the common carotid artery does, so showing that there's no flow. Okay, and then once again they put some Doppler on it, and you can see little to no flow through the vein. Alright, so continuing down the arm, we have the subclavian vein on the left as well as the axillary vein on the right, both with Doppler on them and still little to no flow in either of these veins. Next, they went down to the brachial vein. You can see the image on the left. They did another dual screen imaging to demonstrate no compression versus compression, and the vein still will not collapse. And then on the picture on the right, they did a Doppler image, and there's little to no flow through the brachial vein. So image findings, there is occlusive thrombosis in the left internal jugular, subclavian, axial, brachial, and basilic veins, and the radiologist mentioned that this patient may be a good candidate for catheter-directed venous thrombolysis. So pertinent information, internal jugular vein thrombosis is asymptomatic in the majority of patients. Patients typically present with typical signs for deep vein thrombosis, such as erythema, tenderness, and warmth. And on physical examination, swelling at the left-sided neck, mandible angle, or the anterior border of the sternocleidomastoid muscle can be found. And then labs may show an increased level of D-dimer, which is a degradation product of fibrin that is highly sensitive and nonspecific for venous thrombosis. Treatment options for this include thrombolysis, which is minimally invasive treatment that dissolves abnormal blood clots in blood vessels to help improve blood flow and prevent damage to tissues and organs. And I was interested in this, so I looked a little bit more into it, kind of how it works. So a catheter is inserted into a vein and carefully threaded through the vein with the help of X-ray imaging until it reaches the site of the blood clot. When the tip of the catheter reaches the clot, a clot-dissolving drug is infused into the clot through the catheter, and in most cases, the blood clot will completely dissolve within 1 to 2 days. The procedure is monitored using X-ray and ultrasound scans. These images will help determine if the vein wall is narrowed or damaged, making it prone to more clots in the future. If this type of damage has occurred, an additional procedure may be needed, such as a balloon angioplasty, or placing a small mesh stent into the vein to keep it from clotting again. And then the other treatment option is, of course, anticoagulants, which prevent your blood from clotting. So prognosis of venous thrombosis. In a prospective study, the mortality rate of internal jugular vein thrombosis was reported to be 44%. And then they did say that mortality rate is significantly higher in patients over 75 years old, patients not treated with anticoagulation, and patients with an indwelling central venous line. So this particular patient underwent catheter-directed thrombolysis the next day in efforts to get rid of the thrombosis, and then was instructed to take anticoagulants for the next 6 months. In the radiologist report, he mentioned successful pharmacomechanical thrombolysis and thrombolectomy of the extensive left upper extremity deep vein thrombosis. The likely underlying cause of this extensive DVT is likely a high-grade stenosis of the brachiocephalic vein, which improved after angioplasty. Small amount of residual non-occlusive thrombus is remaining within the left subclavian vein and brachiocephalic vein. It is expected that the thrombus should resolve over time with adequate anticoagulation. This patient was kept in the hospital for a couple of days to ensure that he did not receive a PE, but then was sent home on anticoagulants and is supposed to follow up with his primary care physician.